You're on.
Hi, I'm Dr. Colin Kingston. I'm with Tidewater Orthopaedics. I joined Tidewater Orthopaedics 17 years ago and been on the peninsula since. I heard about Mako Robotics back in 2007 when down in Florida I was invited to go to Fort Lauderdale and check it out. Not knowing much about it, when Mako first came up, it was designed for partial knee replacements, and it had a robotic arm that would assist the surgeon in making very precise cuts to do partial knee replacements, and that's where my interest grew. 13 years later, I am very excited to tell you that now we finally got the Mako robot, and it's much more advanced than it was back then. The capability of the robot includes total knee replacement surgery now, total hip replacement surgery now. It still does partial knee replacements, but soon, in the near future, it'll be able to do shoulder replacement and spine. So, why Mako? What is Mako? Well, Mako is a robot that you'll see behind me right here on the left-hand side that has a robotic arm, and it allows the surgeon to make precise cuts. But there's really three phases to this program. The first phase is the preoperative phase. The preoperative phase involves not only getting plain films, as what the surgeon would normally do when he's doing a joint replacement, but also get 3D CT scans. What that allows us to do is take a very close look at the patient's individual anatomy. There's something called the mechanical axis that you look at the hip center, you look at their knee, and you look at the center of their ankle, and that axis will really help determine how to put in the components. And I'll go into a little bit more detail of that in just a little bit. Then, during the operation, the surgeon will map out the anatomy for that patient, confirming what the 3D CT scan has already showed him or her. Once that's been verified, then the robotic arm can come in and allows you to make precision cuts within 0.5 millimeters of accuracy, which is profound. That accuracy then does not allow the surgeon to make a mistake. There's something called the AccuStop that the robot does that doesn't allow you to go beyond or deviate where that cut is being made. And that's really neat stuff because it prevents outliers from occurring. And then the final phase of the Mako program is the aftermath, the continuum of care after the surgery. All these analytics, all the data that we're about to show you can be utilized to benchmark and compare yourself and coach you along as you're going through your recovery. So without further ado, I'd like to go in a little bit more detail about some of the things I just mentioned. So one of the things that we'll get, and Nadia, my assistant who's in the background, generally there'll be an assistant in the operating room who will be able to help control the computer as the surgeon looks at it. What she's doing right now is showing a 3D scan of a model knee, and she can see where you can line it up in both in different planes, both in the coronal plane and sagittal plane, which are different types of planes, and look at great accuracy of the anatomy as she scans through this patient's knee. Okay, and then once some of that is occurring, then we can also look at, and we talked about, can you show us the mechanical axis? So there's the hip center, so this patient's hip, and then the next reference will be off the medial epicondyle right there, which is the part of the knee that's on the inside of the knee, and then the lateral side as well. So it's basically this 3D CT scan has already fed the computer the patient's anatomy, and in the operating room, the surgeon will verify a lot of these, kind of like when we're using navigation with the scanner here, we'll be able to see everything in it. Once that's happened, before any cuts are made or before any surgery happens, the surgeon is able to look at what the implant will look like specific to the patient's anatomy. This white bone in the background is the specific anatomy to each individual patient. And by doing that, you can start looking at numbers. And one of the key things that you'll hear many surgeons talk about is soft tissue balancing, making sure that the knee is balanced, making sure that when the knee is completely straight, that it feels nice and stable. When it's halfway flexed, that it feels stable, like when you're going down a stair. When it's completely flexed, it feels even more stable trying to get out of a chair and move. All these numbers are telling me things that I can do now before I even have the robot help me do the surgery to balance this knee. So for example, it might be a little bit tight here laterally on the knee. I can actually internally rotate a little bit more and open up that space and rotate the implant to the specifications specific to that patient. What this does is allow us to make changes with the bony cuts and limits the need for cutting more tissue to make the knee straight and balanced. By doing less cutting and less surgery, in theory, the patient will have less pain and faster recovery. Additionally, it also preserves the bone. As the older I get, it seems like the younger my patients are getting that I'm doing knee replacements on. And one of the things, as somebody who does a lot of revision knee replacements on, it's very important to try to preserve bone, especially in younger patients. And this program really allows you to preserve more bone than you would normally would, even with navigation or with conventional equipment. So for the last, I'd say 13 years, since 2007, I've been using navigation, and a lot of you out there that may be watching this right now had their knees navigated by me. The difference between this program, this Mako robotics, and navigation is simply this. Navigation, we would get real-time images in the operating room of your anatomy, and we figure that out. We had nothing pre-operatively to be able to template like this. And the other thing is that we have a sensor like this that would actually look at your knee and look at your anatomy. So in Mako robotics, we still have this piece of navigation, but the big distinguisher is the robot over here. And if you look at the robot over here, it looks like any other robot, and it's a robotic arm. The nice thing about this robotic arm is that I can move it in any plane, any direction that I want to. The equipment to do the surgery would be attached to this arm. We currently don't have that because I actually have a couple of cases tomorrow that I'll be doing, and we need that equipment for tomorrow. But the robot arm, when I go to engage and make a cut, won't allow me to stray even 0.5 millimeters difference, which that kind of precision, no surgeon with just their hand alone can make. So with navigation, I wouldn't have this arm. It would be me making the cut, and I could still make a 1 millimeter or even 2 millimeter mistake with the cut. So I always tell people navigation is about 1 millimeter, 2 millimeter of accuracy. Mako now gives us that 0.5 millimeters of accuracy. So we're really excited about this program. It's something that I've been trying to get for 13 years, and now it's finally arrived here with all these new software programs that will allow us to do already at this time partial knee replacements, total knee replacements, and total hip replacements. And once again, coming soon will be shoulder replacements and spine surgery. All right, so I'll take any questions out there. If people are out there on Facebook or other social media.
You got about 40 people watching right now. And have you...
So the first question...
Sorry, we got a question. What are the issues that can arise from the Mako robot technology?
So what are the issues that can arise using the Mako robot? I think really the only issue is surgeon experience, and making sure that the surgeon basically is very comfortable using the robot and robotic surgery. For most surgeons that have been doing navigation for many years, the transition from navigation to the robot is very, very easy because it's very similar to the same steps. The only difference in the steps is that you have the 3D CT scanning preoperatively, so you already have a plan in place, and you have the robotic arm that doesn't allow even the most minor stray when you're cutting the bone. So it allows you to preserve more of the bone. But that's really about it. So it's, in my opinion, safer to use.
How is this different from computer-directed replacements used now?
So how is this different than computer-directed replacements now? This is different in computer-directed replacements now in that when you use a computer, it just allows you to determine if the cut that you made was what you planned for that cut to be. So there's what we call the verifying device, where I actually put a flat plate with a sensor on it after I make a cut and show a sensor like this to the computer, and it will verify whether I made a good cut or not. When you're using the robot, when you actually make the cut, it's real time showing you, and it's showing that you're taking out the green and you're taking away the bone, and it's showing you real time on the screen that you're making a very accurate cut. And then if you're not, or if you start to deviate even for a millimeter, it won't allow you to make that deviation. It will actually stop your hand from being able to use the saw anymore. So hopefully that answered that question.
Are there any health insurance issues?
Are there any health insurance issues? Yes. Currently, not all health insurances will cover the Mako. The Mako, by the way, is not necessarily an added cost to the insurance company. It's just an added cost to the hospital or surgery center that has it for this improved technology. But yes, not all insurances will cover it. And I don't know all the specific details, but I suspect as more and more literature comes out to support the use and the accuracy of this technology, more and more insurances will start doing it. As of right now, I'm pretty sure that Medicare and some of the top insurance programs all cover it.
All right. Annie's question is this good for someone who has already had a total knee replacement and might need a new surgery due to injury?
Okay, so the question was, I'm repeating it so that you can hear it, was if somebody already had a knee replacement surgery, then goes on to have an injury, is this technology good to do a revision knee replacement, for example? As of right now, I'm unaware that there's any software for that. There might be something in the making because revision surgery is very, very complex in of itself, and as of right now, that does not exist.
Would this technology change the recommendation on how long to wait before getting a replacement?
Okay, so that was a good question. Would this technology change one's decision as far as the timing of when to have the surgery? I don't think so. I think that, to me, that the timing of the surgery is multifactorial. My own indications for doing or offering somebody surgery is when they fail non-operative management, and non-operative management can include oral anti-inflammatory medications, topical medications, including a whole kinds of over-the-counter products, injections such as cortisone injections, gel injections, PRP injections, sometimes physical therapy, sometimes bracing. And once those things have failed, then the person has bone-on-bone arthritis and or moderate to severe arthritis, then I think only then should surgery be entertained. I also have something else, especially for my knee patients, that I call my rule of tens. When people start wearing out their bone and creating more and more of a deformity where they become 10 degrees bowed, or they become 10 degrees knock-kneed, or they start lacking 10 degrees of extension, or start lacking 10 degrees of flexion, I really start thinking about doing the surgery, largely because I start worrying about balancing the soft tissue. A long time ago, one of my professors used to say, what's most predictive of a patient's post-operative motion after a knee replacement is their preoperative motion. And I'll give you a great example. I had a patient who had his leg almost amputated and had it sewn back on, and he had only about 30 degrees of extension, had only about 60 degrees of flexion, for a total of 30 degrees of motion of his knee. When I did his knee replacement, and I did navigation at that time, he had 0 to 90 degrees range of motion when I got done with him. When I moved his kneecap aside, I could bend it to 130 degrees. So his soft tissues, his muscle, quad muscle, became so fibrotic that it wasn't elastic anymore. It wouldn't allow him to bend it anymore. So, but 0 to 90 degrees for him was a good result, even though he didn't achieve our goal of 0 to 120 degrees.
All right. How is the recovery time after this surgery with the Mako? Does the Mako cut down on, or does it have less downtime after a surgery?
Yeah, so the question was, is there more downtime or less downtime by using Mako robotics? In theory, the answer is yes. You know, the less surgery you have to do, the less soft tissue balancing you have to do, the less pain the patient will have, the less swelling they will have, and the faster they should recover. Also, by cutting less bone, hopefully that if they're young, later on in life when they do need to have the revision, there's plenty of bone for the revision surgeon to work with to do a very good revision.
All right. Scott has a great question. How far are we from having the computer do the actual cuts?
So how far are we from the computers doing actual cuts? I don't know. You know, that's a very interesting question because, you know, back in the 90s when I was learning how to do joint replacement, if you'd have told me someday I'd have a computer in the room telling me how good my cuts are and verifying it, I would say that's science fiction. Well, in 2007, that was a reality. And now having a robot in the room preventing my hand from making a mistake when I'm cutting the bone is now reality. So I don't know. I don't know when that will be. I may see it in my lifetime. I certainly hope not to be replaced anytime soon.
All right. Just say hello to Bradley for me.
Hello to Bradley?
Yeah, say hi.
All right. Hi, Bradley.
All right, cool. So, do most patients that have total knee replacements with Mako go home the same day, or is there an overnight stay?
All right, so the question was, do most patients that have Mako go home the same day, or do they spend a night in the hospital and go home the next day? Right now, with our current program, the plan is to be using most of our Mako patients will be going home the same day. I've been doing same-day surgery in the ambulatory surgery center since 2016. We were one of the first, Tidewater Orthopaedics was one of the first to do outpatient surgery with a total joint in an ambulatory surgery center without the benefit of having a hospital bed just in case that patient wasn't doing well. It was a leap of faith, and programs had to be set in place to allow that to happen. I think that as time goes on and the software and the intricacy of the computer interaction with the surgeon evolves, I think that you'll see more and more total joint replacements being done same day. We've already seen that trend, and I wouldn't be a bit surprised if 3 to 4 years from now, 50% of my patients or more are going home same day.
All right. Does the software support all 3 hip approaches, posterior, lateral, and anterior?
Oh, that's a complicated question. I don't know, maybe is there another orthopedic surgeon watching this? The question was, does this software support all 3 different types of approaches to the hip, anterior, lateral, and posterior approaches? And the answer is yes, it does. And one of the things that I think has been a big improvement from the last time I looked at their hip application is that it can be done from all 3 different approaches. Previously, you had to put rays almost on the into the iliac crest, and it would interfere with certain types of approaches. Now that's no longer a factor.
All right. Do you do both knees at the same time?
Do I do both knees at the same time? I have. I've done them 14 times in my career. I've tried to talk people out of doing them both at the same time, largely because despite all the improvements in technology, it's still a pretty big hit to take. And out of the 14 patients I've done both knees at the same time, When I asked my patients if you do it all over again the same way, only 1 out of 14 said they would do it the same way. But what I do when I started doing back in 2010 was doing staged knees. So I have a lot of patients who don't want to miss out on work too long, want to kill 2 birds with 1 stone, so to speak, with physical therapy and not have prolonged physical therapy for both knees. I will do the other knee or the other hip 2 weeks later, and that has worked really well for me. 2 weeks has been just about the right amount of time to start trusting the knee, to have your quad muscles, your muscles from the surgery starting to recover, till you trust it to where we can do the other side. So for a lot of my mostly younger patients, what I mean by younger, 65 years and younger, I will do them staged oftentimes 2 weeks later. And I do that probably about 60 times a year.
Is there less PT time after the knee replacement when using the Mako?
Yes, in theory, because there's less dissection, there's less soft tissue that you're releasing, there's less pain and swelling, there should be a need for less physical therapy. Right now, out of the Mako knees that I have performed, so far that's been holding very true.
All right. How young can you get a knee replacement?
So the question was, how young can you be to get a knee replacement? The goal is always to try to hold off on younger patients as long as you can, and the reason for that is that artificial knees, and again, despite all the improvement in technology and design of them, and there's been quite a few improvements, have a finite number of years that they'll last. Just like an automobile will last only so many years, an artificial knee will last only so many years. Knees that I was putting in over 20 years ago in the lab were lasting about 18 to 20 years, and I have enough experience now, 24 years experience, to tell you that 18 to 20 years is about right. Knees that we're putting in today in the lab, particularly the knee that I use, Stryker Triathlon knees, are lasting close to 33 years in the lab. So I tell people, hopefully we'll get 30 years or more out of this knee. But again, there's a multitude of factors that play into that. People's weight play into that. The heavier you are, the greater load you're putting across the implant. And the weak link of any knee system, for example, is the plastic. That's what wears out. And when that wears out, then the metal becomes loose, and then the surgeon will need to revise the knee. So I tell people, as a rule of thumb, we try to hold off on exhausting all conservative treatment before we do knee replacement in young people. For some young people, the options may be doing other type of sports medicine procedures. The one thing about myself is I have the distinguished privilege of not only being a total joint specialist, but being a sports medicine specialist. So I take care of a lot of young athletes that have what we call grade 4 lesions, where they just have exposed bone and have lost a significant amount of cartilage. For those patients, oftentimes there's arthroscopic procedures that we can do to try to stimulate their body to grow cartilage or fill in that with scar cartilage, and or sometimes even use a dead person cartilage and bone to fill in large defects. And these type of procedures, again, are temporary procedures to give you 10 to 15 years maybe of relief, so that when the patient is old enough, then only then do you start thinking about doing an actual replacement with metal and plastic.
What's the normal downtime after the surgery, and how much time can someone expect away from work?
Okay, so what is the normal downtime away from surgery, and what's the amount of time people can expect being out of work? So far, my experience is that for most of my patients that I do either hip or knee replacement surgery on, they're out of work for about 1 month. For some of my patients, depending on their job, for example, somebody who's a roofer who will be on inclined angles, they may need to be out longer than that, maybe 2 to 3 months. I have had the privilege of doing 3 of my own employees, 2 of them, and they're on their feet all day long. 2 of them were back at 1 month, 1 of them was back at 6 weeks. So I think that's a fair estimate.
How many total knee replacements have you done, do you think?
How many total knee replacements have I done? I do probably around 100, about 200 a year, and I've been in private practice for 17 years, And when I was in the military, prior to that, I did not do nearly as many. In the military, I was doing probably 20 to 30 knee replacements a year, and now I'm doing about 200 knee replacements and probably about 50 to 75 hip replacements a year.
All right. After hip replacement, how should I feel the pain when I walk and get up after I sit down?
So the question was, after having a hip replacement,
how should I feel the pain when I walk?
How should I feel the pain when I walk, going from a seated to standing position also?
Yeah.
So the question's worded a little bit different. Let me try to interpret the question. I think what they're asking, should I feel pain when I go from a seated to standing position, and should I feel pain when I walk? It depends on the time of your recovery, and it depends on the approach that your physician utilized. For some people, for example, who have a anterior approach, they'll sometimes have, not everybody will have numbness around the incision, which happens in a certain small percentage of people. Sometimes they'll have pain when they go up a steep stairwell and flex up their hip, but that's usually short-lived until the muscle that was split or pushed aside heals. And the side, typically people will have pain when they go side to side or lay on their side, and in the back, usually they don't have as much pain in my experience, having done all three approaches. So I think it just depends, but most patients, once you're beyond a certain time frame, it's very unusual to still have pain when you go from a seated to standing position or when you walk. If you're still having pain beyond 2 to 3 months from your surgery, I would definitely make sure you follow up with your surgeon and make sure nothing's going awry. Things that can go awry that can still cause hip pain beyond that can be the first thing that I tell all young surgeons and physician assistants is pain is the #1 symptom that people have when they have an infection. So you want to make sure, #1, you don't have an infection. And #2, you want to make sure that the implants aren't loose and that they're well fixed because that can happen also. But pain beyond 3 months, especially for hip replacements, is unusual. For knees, it's not atypical. About 25% of people will still have pain beyond 3 months after knee replacement surgery. So knee replacement surgery is a different animal.
Are you, what's the difference between the jiffy procedure and the robotic procedure?
Okay, so the question was, what is the difference between the jiffy procedure and the robotic procedure? When people use the word jiffy, what they're trying to impart is that they're trying to do less dissection, less surgery through a particular approach. And I'll give you an example. With the jiffy knee, for example, which is being now marketed, there's 3 ways to make an incision around the kneecap. There's one way to go straight across where you avoid the muscle, and that's called a subvastus approach. There's a way to go in the middle of the muscle, and that's called a midvastus approach. And there's a way to go around the muscle along the edge of the tendon, and that's called the paramedian approach. Some surgeons are marketing that the subvastus approach is the jiffy approach because they believe that it will be less painful for the patient, faster recovery. However, studies have been done comparing all 3 approaches. I've met with 2 of the busiest orthopedic surgeons in the United States that do more knee replacements than anybody else, and all of them agree that, and they've all done all 3 approaches, including myself, that there's no difference in recovery, no difference in bleeding, no difference in the patient's ability to do a straight leg raise, walk, and recover. The problem with the subvastus approach, which is being coined the jiffy knee, is that your exposure to the knee is limited. And sometimes when you have limitations, especially in a big muscular person, it can make it very difficult to put the components within a degree of accuracy. The nice thing about robotic surgery, whether you choose the subvastus, midvastus, or paramedian approach, it won't allow the surgeon to put the components in without that certain degree of accuracy. So robotic surgery is not so much the approach that you use to get to the joint. Robotic surgery is what you do once you get down to the joint, and it doesn't allow you to make mistakes with your cuts so that you don't have any outliers with regards to the position of the components. But really, honestly, I tell people with the type of approach that your surgeon uses, ask them why they use it and why they prefer to do their approach. And I think that you'll get varied answers from all of them. For somebody like myself who's used every approach in the knee and somebody who's used every approach in the hip, I have my rationale behind both. And for somebody who now, later on in his career, is doing more and more revisions from cases that have been done mostly elsewhere, the approach does matter because it does impact that surgeon's ability to do a really good revision.
Are you put to sleep during surgery or twilight sleep?
So the question is, do you go to sleep during the surgery or do you go into a twilight sleep? One of the things that has really changed our ability to do total joint replacement same-day surgery is what our anesthesia colleagues are doing. One of the things way back when, over 20 years ago, we used to have patients have epidurals put in, kind of like when women are having children, to numb up from the belly button down. And that would be incredible. It would help tremendously with the anesthesia, but it would numb up the muscles also. So you'd have no use of the muscles, and you make it very difficult for you to get up. But one of the risks of surgery with joint replacement surgery is blood clots, pneumonia, bed sores. All these complications can occur from not being active and mobile. Well, an epidural doesn't allow you to be up and mobile and puts the patient at risk for developing these problems. We then went to start in somewhere about 10, 15 years ago, we started doing regional block anesthesia, where the anesthesiologist would numb up the nerves right around the hip and right around in the buttock region to make the leg go numb. Again, that way you didn't have problems with bowel bladder dysfunction. The patient could get up in theory, but still would have a wobbly leg because their muscles wouldn't be working. Now, anesthesiologists are making the blocks actually much closer to the sensory nerves and not affecting the motor function of the nerves, which is called an adductor block and a block in the back of the knee that will help with the pain post-operatively but not impede the patient's ability to get up and start walking with getting the feeling that their muscles wobbly or will give out on them. And similarly in the hip, most surgeons now give lots of medications in the soft tissues in the hip to help with the pain post-operatively, to allow them to start ambulating right away. So our protocols post-operatively have changed dramatically, to where most patients 2 to 3 hours after they have their hip or knee replaced are up and walking, putting full weight on their extremity.
All right. How many Mako replacements have you done? And maybe discuss some of the training or something?
Yes. So I haven't done that many Mako replacements yet, but I'm hoping to do many in the future. Right now, I believe I did five. I've done about 5 Mako replacements right now. But as time goes on, I'm anticipating I'll probably be doing close to 25 to 50 probably in the next 3 or 4 months. And then maybe in the future, maybe close to half my joint replacements will be Mako. It really depends on insurances and the patients that are coming to me, their insurance, whether they'll cover it or not, as far as the preoperative planning and all that goes along with the Mako.
All right. I think you already did this one. After the Mako procedure, how long will you be out of work?
So the question again was, after the Mako procedure, how long will you be out of work? My estimate would be about 4 to 6 weeks. Right now, I don't have a large volume of Mako replacements, but that may change in the future.
All right. Good question. Can you wait too long to have a joint replacement?
So the question was, can you wait too long to have a joint replacement? The answer is yes, absolutely. I have way too many patients that I see on a regular basis that I continue to manage non-operatively because they did wait. So I'll give you an example of one of my patients. She was 78 years old and had just retired at age 75, wanted to start traveling, felt that if she had her knee replaced that she would be out from traveling while she's young enough to still travel, even though she had bone-on-bone arthritis, and all she wanted was cortisone injections in her knee and some anti-inflammatory medication to help her go on her trips. Well, over the course of 2 to 3 years, she became less and less mobile. She gained 40 pounds, and at the age of 81, she had a stroke and became paralyzed on that side, to where she had a hard time getting up and moving. Now she has a hard time, even though she's recovered partially from her stroke, putting weight on her knee, because she now has greater deformity in her knee and bone-on-bone arthritis. And the only thing I can offer her, because she doesn't have the power or ability to undergo a knee replacement, is cortisone injections about every 3 to 4 months. So I do tell people, you want to be young enough and healthy enough to have it done, but you want to be old enough that when you have it done, hopefully it will last you for the rest of your life. And that's different for everyone. I tell people chronological age doesn't necessarily mean physiologic age. I have some patients who are 80 years old who are still running marathons, and physiologically they're 40 years old. I have other patients who are 40 years old who are physiologically 70 years old with bone-on-bone arthritis and a multitude of medical issues.
All right. How many other places around here use Mako?
So as far as I know, there's only one other facility around here that uses Mako, and that's at Mary Mappett Hospital. The difference between this Mako and their Mako is we have the ability to do total knee replacements and total hip replacements, which is new to this region. And that's why I'm sharing this technology today, and that's why I'm so excited. But I'm also excited about the near future with its ability to be able to do shoulder replacement surgery and spine surgery. So it's really a matter of the technology coming in, and we just open the door, and it's going to be like a floodgate. So I'm very excited about it.
That leads right into the next question of how long you think it'll be before we have the software for those shoulder and spine.
It's hard to predict, but I would tell you that my guess is that the shoulder will probably come first, probably sometime next year, maybe towards the end of next year. And spine may take a little bit longer because spine can sometimes be a little bit more complicated. But I think that's my gestalt and prediction, but it's hard to predict. There's a lot of things that every company, when they come up with new technology, have to go through various steps to get FDA approval.
I think we're good. How can people, when can they get an appointment with you?
Okay, people can get an appointment with me at any time. I'm more than happy to talk to them about Mako. Like I said, I'm really excited about the technology. I've been trying to get a Mako for 13 years. Everybody who knows me knows that that's what I've been trying to do, and I'm really excited to introduce this to everybody out there.
Oh, so the couple came in. Is this the same as Dr. Higgins does? That's the question.
Yes.
Yeah.
So I'm with Tidewater Orthopaedics, and the people that are using Mako and will be using Mako will be myself, Dr. Kingston, Dr. Higgins, who's my partner, Dr. Payne, who's my partner, and Dr. Sablan, who's also my partner, and then Dr. John Mason, our spine surgeon.
Can it be done on ankles?
Can it be done on ankles?
Yeah, that's Pelton.
Oh, and Dr. Pelton, who just joined us, who's one of our new partners, actually. So there'll be the vast majority of the Tidewater Orthopaedics will have the ability. Just like anything else, though, we have to go to a course, be certified in it. You have so many cases that you have to do on a cadaver, a dead person's body, before you can be actually certified to show that you're proficient at using the technology. And what we have found is that all of my partners that have been using navigation for the past over a decade became very adept. The learning curve was very easy for us in making this transition.
And in which hospital are you using this?
I'm using this hospital currently at the Careplex Orthopedic Ambulatory Surgery Center, and hopefully soon at the Orthopedic Hospital at Centera Careplex.
All right. I think you already answered this question too, but just what do you think of the jiffy knee?
What do I think of the jiffy knee? Personally, I don't think there's any difference between the jiffy knee and doing a standard parameter approach. I'm always concerned in younger orthopedic surgeons that try to market themselves as being unique or different. by coming up with a approach that's been around for many, many years, and coming up with a coined term like jiffy, and no data to support superiority over that approach over other approaches.
All right, I think that's it. If you want to ask if anybody else has any more questions.
Does anybody else have any more questions?
Before we get out of here, and tell them they can make appointments online at our website.
They can make appointments online at our website, which is
TidewaterOrtho.com.
TidewaterOrtho.com.
Hit book now. They can get appointments with you very quickly.
And they get appointments with us very quickly. All right?
Cool.
Have a good night, everybody.
Thank
Thanks
you
for
very
joining
much.
us tonight.
Yeah.
Take care.
I'll cut this guy.